So we're back talking about supporting next generation HIV prevention options and how we can leverage JSI's experience in new product introduction. JSI has a deep history in facilitating market entry through demand forecasting, market analysis, market shaping, data visualization, advocacy, human-centered design. And some of our global expertise is working with and coordinating with product developers across the value chain to identify gaps and market opportunities. And today I have the pleasure of speaking with Tanvi. Let her introduce herself in just a moment, but one more time, my name is Maher. I'm a senior HIV advisor with JSI's HIV and Infectious Disease Center. So Tanvi, thanks so much for joining me in this conversation today. And as a welcome and introduction, would you tell us a little bit about yourself?
Sure. My name is Tanvi Pandit-Rajani. I'm the private sector health markets lead at JSI, and I work across all of our various technical and program centers, supporting, efforts around private sector and markets, as well as new business development. My background is I started my career working at USAID as a commodity security advisor, and have since worked at different organizations focused in the area of policy, as well as private sector service delivery, all sort of intersecting with, markets and commodities.
Excellent. Well, it sounds like you're the perfect person to talk to. In addition to that experience that you just listed, I know you also have supported PrEP rollout, the implementation side, and various family planning products. So as we are obviously looking at HIV biomedical prevention products at this time, pulling in those experiences and lessons learned, I think is how we're going to leapfrog and ease the rollout. So would you start off by just talking about your thoughts on these new prevention products as far as you know them, and how you feel the health system, public or private, is ready for that introduction and scale up?
Sure. So, to be perfectly honest, my experience with many of the HIV prevention biomedical products is it's new. And we're trying to take the learning that we have from contraceptives. And what I would see as sort of the similarities across what's coming out, both on the HIV and the family planning side, is this movement towards self-care. And how do we really think about and position these products to, enhance the agency of the people who are intended, who are the intended users of these particular products and services. And so by and large, because many of these products are supported through donors, they often begin with public sector programming, where there's, a much more, I think, organized system in which to deliver, and not only to deliver, but to match that delivery with demand generation and SBCC. But increasingly, what we're seeing also is that funders as well as governments are trying to think about this from a whole market perspective, recognizing that some of the audiences or people that need to be reached aren't necessarily seeking those services in the public system. And so how do we engage the private sector strategically and effectively, not just in terms of delivery, but also in terms of some, reaching sort of that, we're talking about that client-centered approach. So it's matching that, awareness raising and demand side effort alongside, ensuring that there are a variety of channels for which people can get the kind of products and services that they need. And so as I was saying, so increasingly we're moving towards thinking about the role of the private sector as well as the public sector and reaching everyone.
Excellent, thanks. I definitely want to get into those various channels, but before I do, I love that you framed this as self-care and talked about agency of the end user. And I think that's critical, engaging the community, understanding their wants and needs. Can you talk a little bit about your experience through either behavioral economics or human-centered design, and how that has helped with the various products that you've worked on, and how we could use it moving forward?
Yeah, I can certainly speak to human-centered design. We've not just used it in terms of a new product introduction, but used it in a couple of other instances to help design not just the policy, but what the program, engaging those end users as part of the policy and program design. So often when some of these products are introduced into markets, you know, there's a policy environment that needs to be considered as to, what does, who's allowed, what is the profile of the particular end user or client that needs to be served, who is allowed to provide, what are the inputs required for that provision, where should these products be placed, are we allowed to charge or not? There are a lot of these sort of policy related questions that, if a product is provided through a private sector, but they're a donated product, can the private provider charge? So there's these sort of operational considerations. And what human-centered design has allowed us to do is to bring those end users into the discussion, and to also bring in actually providers into the discussion at the policy level. And so what we've been able to do in a few countries already is part of it is the convening. But before we even convene, it's the important conversations that we're having with different types of actors across the market and the system. So, from that policy level provider to end user, but everyone in between. And then when we're talking about private sector, we're also talking about private associations and private, say pharmacists, for example. So if we were to take the example of DMPA-SC, where there's a self-injection component to that, one of the big questions is what's the role of pharmacists? Are they allowed to train women in self-injection? Are they allowed to actually provide the injection for women who don't want to self-inject? And this has become, an interesting sort of policy discussion, partly because in many of the countries where we work, community health workers are in fact allowed to provide an injection, whereas, pharmacists in certain contexts cannot. So what HCD has allowed us to do is kind of unpack some of these issues at various levels. And it has also allowed some of those policymakers to really hear from the end users and have a dialogue, which often doesn't happen. And so that's really been interesting in our work to see that unfold and see how it's also contributed to, a different type of service design or a different type of policy design.
That's really interesting. The way you describe the end user as everyone in between really opens it up to every level. I mean, more than just the program beneficiaries, as we would traditionally call them. When you talk at the policy level, outside of HCD, are the actual end users, the end users of the product being heard? And how do we ensure that always happens?
So part of it is that we, as JSI, have often operated as facilitators in the process and working alongside. So we would bring, like, for example, someone with core expertise in HCD alongside someone with, say, technical expertise in, family planning or DMPA-SC or whatever or community health, whatever the service focus is, whatever the priority is. And so we bring that programmatic expertise alongside the HCD. And part of our role is to ensure that those voices are heard. And so it's that convening part that I mentioned earlier, where after going through these, what we would call consultations or immersion sessions with the different actors, it all culminates into a select, and we have to be mindful of the size of the group as well, but being mindful of the size of the group and the type of workshop that would lend itself to interaction. And so, having been through a few of these now, you see debate, you see a thoughtful debate, and you see that what comes out of it is something that people, eventually there's consensus around, but the process for getting there really allows the variety of voices to be heard, including, but not limited to, the end user, because it takes everyone from the policy level down to the end user to get that buy-in for what's needed.
Now, going back to channels for a moment, I mean, obviously, I think offering it in multiple venues between the public and private sector really gives the end user the ultimate choice, which makes sense. Can you talk about your work with total market approach and how that informs these decisions of where to offer the product and not knowing which product is next? Any advice or recommendations on whether it's the Dipivirine vaginal ring or injectable PrEP on some of considerations on how we would apply TMA?
Sure. So I think part of it for us, or a big part of it for us, is starting with the client and thinking about, or that end user, right? So what are the choices that are available to them? And the choices that are typically available will depend. It depends on where they live. It depends on what they can afford. It depends on what they may have access to, where they feel comfortable. But in theory, in many of the countries where we work, there are a variety of channels where products and services are delivered. Whether those channels adequately meet their needs is a different, probably different topic. But if we think about the potential for all of those variety of channels to meet those needs, then the question is, well, then what do the interventions need to look like to make sure that we're increasing access to the people that we are actually needing to reach? And so from a TMA point of view, what we often think about, and it gets complicated when we're thinking about, say, one product. So I'm going to pick on DMPASC for a moment. When the introduction channel is a public sector introduction channel, typically it's something that is offered for free in the public sector. And when we start to think about what the role of the private sector is, I think we have to think about, well, what would motivate the private sector to offer this particular product or service? Is there, at the end of the day, while they are committed to health, they're also, as a private business, looking to see whether there is something to be, what's their motivation in terms of, is there a profit to be made here? And I don't say that I don't mean that at all in a negative way. So, if they're going to charge for a product, that to me is going to affect, where a person may or may not go, or whether they see value in paying for a product over here when it's offered for free somewhere else, right? So then you're starting to get into people's willingness to pay, whether they're able to pay, whether they actually have access to those particular service points. So I think the work that needs to be done from a TMA point of view is that when we support an intervention through a particular channel, what are the potential implications for introducing or providing that same product or service through other channels? And so there's a relationship there. And often, clients may even, they may use both public and private to meet different needs, right? So it's really, in my mind, it's really getting to understand what are sort of the drivers of certain behaviors, what are the drivers of where people go and seek care, what are the drivers that prevent people from seeking care? And then based on that, then what is it that we as implementers, how are we responsive to that?
Interesting. When you mentioned the willingness to pay, I think another driver is value, and how are we creating value around the product? Specific to injectable contraception, as the example you've used, how did that work in the private sector? And were you able to, I guess essentially, are you able to charge for it there?
So the way that it worked for DMPASC in Zambia is that we came in at a time when that particular product had not yet entered the country. However, it had entered into other countries within sub-Saharan Africa. And much of the experience with those introductions had largely been either community-based or they had been public sector focused. And what we hadn't seen yet is if we wanted to introduce it into the private sector, what would that look like? And the challenge that we wanted to help solve for was that the type of clients that you would have that go to the private sector typically don't look like a community-based or a public sector client. And so when it came down to thinking about, well, how do you train providers? And then how do those providers train clients to self-inject? The design that that sort of was being used in other sort of public sector community-based programming did not translate as well to private, where, women often want to be in and out. They may not have time for a 45-minute training. Private providers may not have time for a 2 to 3 day training because they're trying to run their own business. So when it came to Zambia, we really had to think about, well, how do we adapt the content that's there to something that would lend itself well to the private sector where women are paying? And what we did was because the supply is coming from donors, and therefore it's coming through first the public sector supply chain, and we basically were able to access that for this particular work. Private providers were not allowed to charge for the product, and that's policy. Anything coming free from the government supply, private providers cannot charge for. But they were allowed to charge for a service. And what we did was we also looked at willingness to pay. So because this was a new product and women didn't have any experience, they had experience with an injectable contraceptive, which was DMPI-M, which is injected intramuscularly versus subcutaneously. There was already some demand for injectables, but the self-injection component part was new. And so what we did was we conducted a willingness to pay study alongside our introduction. And we asked, questions around willingness to pay before the woman used the product. And then we asked several questions around willingness to pay after their experience with the product. And what we found was that women, sort of the before and after, by and large, their willingness to pay actually went up after their experience with the product. It was fascinating to hear how women truly felt empowered by being able to inject themselves. I mean, it was really wonderful through the HCD process for us to get those insights and to share those insights back as part of the broader workshop where policymakers got to hear it directly from those end users. But what we found was that the price that women were willing to pay was on par with what donors are paying for that product in terms of unit cost. The challenge, though, is that if and when that product comes down through a commercial or private sector supply chain, there's markups that happen along the way, and private sector doesn't necessarily have the same access in terms of pricing that donors do. And so, the pricing will look different if it's a purely commercial product. And so I think the thing that we have to think about is how do we understand what those markups look like? How can they be better, perhaps regulated? How do we think about, increasing the access for private commercial suppliers and importers, so that they're not starting off at those high price points, so that eventually it does become more affordable, by the time it hits the service delivery point.
Interesting. Well, I'm so glad that you used the example of injectable contraception, because I really do think it is so related to two of the new products coming down the pipeline, and that's the pipeline vaginal ring and the dual prevention pill, which combines PrEP and contraception. But as you just finished talking about kind of negotiating with suppliers and kind of getting involved earlier in the supply chain, are those activities that we could be doing now? And what have we learned about market entry and sustainability? And I guess the question is, what should we be doing now in advance of these products ever hitting the ground in any of the countries we work in?
That's a great question. I think part of the planning ought to consider what a private introduction would look like. And I think what it looks like will depend country to country, depending upon what the potential demand and the potential needs are for that particular product or service category. And at the same time, we also have to recognize that countries are at different stages with respect to, what the private sector sort of makeup looks like. So, I'm going to pick on Mali. A Mali is going to look very different than a Kenya. And so, as we think about planning, I think part of that is when we consider what is the starting with that end in mind. If we're going to introduce these new products where there isn't a proxy product the way that there is for you've got DMPA-SC, but there's already such a strong demand for DMPA-IM in many of the countries that we work. But for some of these new products where there isn't a proxy, there's a little bit of an unknown. And so I think there's got to be some initial, as we think about, well, what is sort of the next 5 years, where do we want to be with this? And what would we like the private sector role to look like? And what makes sense for country X in terms of charging and not charging? And if there's only one product, how do we sort this thing out where it's free over here and can it not be free over? I mean, how do we work this out? Like, how do you charge in one place and not the other? And do you place it in certain places where it's free away from the places where you're charging? I mean, so some of this is really we've got to look at what's going on in a particular country and what the country is ready for. And I think about, this is an example of condoms, for example, in Zambia and other countries where we've seen, for whatever reason, a programmatic break in, say, the social marketing of condoms. And what happens when there's a long hiatus is that there is a market response to that where commercial sector comes in. Now, condoms are a very different product category. It's not clinical. It's there's a diversity of brands and that sort of thing. And so perhaps it's not the best, it's not the best example or reference point, but I do think there's a learning from what we've done in the condom programming world. And, there are markets at play. And so how do we think about introducing what is a public health good and where we feel everyone should have access, but how do we do it in a way where we're thinking about sustainability from the beginning? And if we think about it from the beginning, I think that we would design differently. And so that is perhaps where maybe the HCD component comes in, where, you bring in through an HCD process of, what are the respective goals? And you might find that the goals aren't totally in alignment when you're talking to different stakeholders. And you also might find if the original goal was to put this all to the public sector and scale that way, that maybe the people that we're trying to reach don't go there. So, for me, I would say, how do we think about what our goals are, not just for sustainability, but for equity? So those two goals, sometimes where we often have both, aren't always necessarily aligned in terms of how we implement. And I think it's thinking about what does the market system look like in a particular country? Where do people go, if at all, to get their product or service? And designing with that part from the beginning versus at the end when you're saying, hey, donors aren't going to support this anymore. We need to think about the role of the private sector, which ends up being reactionary versus proactive.
I see. Well, it sounds extremely complicated, but also very exciting, as we will have multiple products, multiple HIV prevention products, and offered in different spaces and at different levels, and really trying to tailor to the end user, which is the ultimate goal. Let me finish. I know we're getting close to time. What are you most excited about in terms of these upcoming biomedical prevention products?
Oh, wow. I feel that so many of the products that are coming online put the power, give the power to the end user, and help create some agency around, what they're able to use. It's that whole self-care, part of that self-care movement, I think, is how do we think about how to take care of self? And there's many ways to do that. And then now you've got options, multiple options, not just, more than a handful of options. And so I think some of the technologies that are coming out are really thinking about how do you put the ownership in the hands of the people who are intended to use these particular products and services. And I think that's really exciting.
Agreed. Well, Tanvi, I want to thank you so much for taking time to speak with me today. This has definitely been illuminating. Any last words or advice to countries, to programs, NGOs as they are embarking on this, at various levels of the new product introduction cycle?
No, no advice. I think that what I think many of us are increasingly seeing is the important recognition of the role of the variety of service channels and public and private that are there to meet the diverse needs of countries' populations. And how do we be more sort of strategic about doing that? I think countries are already thinking about that. I think donors are thinking about that. And I think one of the things I'm most looking forward to is being part of that shift that's happening now.
Fantastic. Well, I'll make sure that some of the resources on the new product introductions that you mentioned are available on jsi.com, and we'll hyperlink them along with this recording. So again, Tanvi, thank you so much. I appreciate your time.
Thank you. Thanks, Sean.